So if we could have the speakers come up, we can start with the panel. I have a question for you, Marc, right away. In the case of tricuspid replacement that you just showed, how do you handle the area of the conduction tissue, number one? And number two, how do you handle pacing wires? Do you put permanent pacing wires in all those patients or what?
So, particularly in patients with endocarditis, I mean, you have no choice but to remove the infection. So in those patients, I may consider putting some epicardial pacing wires on. But in other patients that we do replacements for other issues, I don't routinely put the pacing wires on. And the area of the conduction, I tried, if I can, I try to leave some leaflet tissue to sew to, if it's possible, if it's not infection.
So Sloane, there's a question for you. The robot approach is appealing, but can you explain a stepwise and safe way for me to do it? Do you think I should start with a mini thoracotomy?
Sure, I think that's a great question. The first thing I would do is a self-assessment, an honest self-assessment of yourself and your program. And the number one question is, do you have enough mitral valve volume to begin with to really launch a program? And I think the magic number for me would be about 50 cases. If you or your partners, can't muster 50 mitral repairs, probably not the way to go. Now, you can still get into robotics with a robotic mid-cab, limited LAD. That can be done in those type of environments, but do an honest assessment of that. I think it's very reasonable to start with a right mini thoracotomy first, without the robot, before you start adding the robot, because there's basically multiple skill sets. There's the right mini thoracotomy, there's the robot, and then there's the circulatory management, the endoballoon or the Chitwood clamp or whatever you want to do. I think if you're going to do what I'm doing from the get-go, you probably ought to spend a pretty good amount of time with someone like me, and there are many of us, Sam, many others throughout the country, really learning how to do the operation from stem to stern. If you're going to do it sort of on your own, a stepwise approach for mini thoracotomy with robotics, smaller mini thoracotomy with robotics, endoballoon, totally endoscopic is probably a reasonable way to progress. But it's a serious undertaking, not just for you, but for your team, because you're going to have to train your team to do this. When I moved from Philadelphia to New York, it took me about 3 months to train my team at Cornell to support these operations before I felt comfortable doing a case. And that's because they had no minimally invasive experience whatsoever. So don't underestimate the impact of this on your team and to train them specifically.
Yeah. The second question, for pain control for both of you, what exactly do you do for?
Yeah, so
You don't have any pain. How you doing?
Yeah, exactly. Thank you so much. Yeah, robot patients have zero pain. No, they have pain. What I like to tell patients is, because it's a lot about expectations, which is my first step for pain control, which is these are very minimally invasive incisions, okay? But it's not zero pain. If some guy came and stabbed you with a pencil 5 times in the right chest, you're going to have a little pain, and I'm that guy. But we use the paravertebral pain block with regular bupivacaine at the beginning of the procedure. I used to use bupivacaine at the end of the procedure, but I found it worked a little better if we gave it at the beginning. And we also give Neurontin postoperatively and fairly liberally, along with Toradol. What we found is the pain usually goes away within a couple of days. So it's usually the first 24 to 48 hours that they need pain control.
Marc?
We only have one incision that requires pain relief. So,
in addition to the chest tube, is that right?
so if we're doing a cryo maze, we'll take the cryo probe into the intercostal spaces and freeze about 4 or 5 spaces. That gives us pain relief for quite a while, actually, sometimes a little too long in my mind. Patients do complain of some numbness sometimes 3 or 4 weeks afterwards, but it does do a lot for pain relief. If not, then the anesthesiologist do a rib block at the end of the procedure.
The next question is about CO2 delivery. First, Marc.
So I take a diffuser device and I place it right into the incision. I just kind of tack it there at the skin, and I diffuse it 10 liters throughout the entire procedure, at least while the heart's open.
It's very simple for robotics. You just hook it up to the robotic ports, and with the XI, every port has a connector for the CO2, and we usually run it at a flow of 8 and a pressure, flow of 5 and a pressure of 8 during the initial parts of the procedure, and we do insufflate the right chest in order to create working space. Once we go on bypass, though, we turn it down to 1 liter and a pressure of 1 in order to reduce any risk of unilateral pulmonary edema or injury to the right lung. And also, you don't want to pressurize the right chest positively when you're inside the heart when you're using the endo balloon, because you could theoretically push that endo balloon out and cause a CO2 embolus. But I think that one of the advantages of a completely endoscopic approach is that, and we've never measured it, but I'm sure if we did, that the CO2 environment, it's very high CO2 concentration within the right chest because there's no place for it to go.
I wonder if, first of all, thank you for these talks. They were really great talks. I wonder if you could provide us with your thoughts on the importance of teamwork, by which I mean engaging your administrators, engaging your OR leadership, the people that are actually going to be doing the surgery for you, and doing it well before you even take the first step to doing such an operation. That's one thing. And the other thing is to talk about the importance of the culture of safety and how you inculcate that in everybody that you're working with.
Mahesh, that's a great question. It's one of my favorite questions because when I look at the skill sets required to do robotics or high-end minimally invasive, I would say number 1 is teamwork and team leadership, which is what you're alluding to. It cannot be underestimated. And I have a saying that I use with starting robotic programs, that you've got to get the heads of the 5 families on board from day 1. So, surgery, anesthesia, perfusing, nursing, and administration. And any one of the heads of the 5 families can torpedo you and make things unsuccessful. So you got to be a little bit of a politician and get buy-in from those individuals. And frankly, if you don't have it, then you probably should not proceed. There are environments where I could not do a robotic mitral, and I might have to scale back and do something different because, say, administration doesn't really support it, or the surgery chief doesn't support it, or whatever. So you really got to do that, and then get the team together and have meetings. So when we started the program at Cornell, we had weekly planning meetings, and after each one of those meetings, I would generate notes and send them out, not just to the team members, but to their leaders. Okay, and then we would do mock cases. We actually did a total of 10 mock cases. And one of the beautiful things about the way Mahesh has set this conference up today is I'm going to show you today how to set up a mock case. So the demo that we're going to do is actually the mock case that you will do in your home hospital to get ready to do these procedures.
So I think to add to Sloane's experience, one thing I heard from him that I thought was really valuable is the mock case was in the OR. It was on the schedule. Everybody knew this was being prepared for, this was going on. Everybody knew. Yeah, so they got tired of seeing it. They're like, oh, okay, there's another mock case. Yeah. So it wasn't like, oh, there's a robot case going on in room 1 and it's taking extra time, et cetera. I think that was very important.
Yeah, that did go over well. Now, we had to have support from our hospital administration to do that because that's not an inexpensive item, 3 hours in a busy operating room in New York City. Exactly. But they bought into the concept that this is what it would take.
So I think that's important for any of these procedures. The last thing you want to have happen, at least in my mind, was I didn't want people to walk out into the hallway and say, oh my God, an operation that they used to do in 2-3 hours is now taking 8 hours to do. And so I got the team together. I actually took them with me to a training session with Joe Lamellis down when he was in Miami. I spent 2 days with the team. We really all had a job that we were going to do when we were there, and they bought in. It was a good way to build the camaraderie. And when we came back, when they walked into the hallway and someone said, oh my God, what's taking so long? The guys in the team said, it's going great. They bought in. I think it was very important to have that. I recommend that people do that, just like you did, interact with the team,
and I can
make them part of it.
And I can also say that I went and watched Dr. Sakwa and his team, and we learned a great deal from him. But I tell you, the teams the surgeons that show up at my place by themselves, fine, maybe they're going to sort it out. But if they're truly playing at a launch, generally don't make it. The ones that show up with their scrub tech, their PA, their circulator, maybe even their administrator, their team, those are the ones that make it because they get to interact with the team members. And they also see what the finished product looks like. They can visualize where we're going. So if we're going to learn parasternal AVRs from Dr. Sakwa and we go and look at him and he bangs one out in an hour and a half and it's smooth as silk, they come away from that saying, yes, this can be done.
We had an experience similar that you described when we started in Long Beach. We'd already had a large mid-cab experience and a busy mitral experience, and we had started doing thoracotomy mitrals for some time. But before we got the robot, partly because our hospital took so long to get it, we spent a year putting in coronary sinus catheter in everybody, putting a PA catheter in everybody, doing all of the external learning curve procedures that we needed to do in sternotomy patients so that we weren't learning 5 things at once. I think that was one of the key failures of the original Heartport. I counted 8 different learning curve procedures that were initiated in the Heartport experience, and that was pretty much, except for a rare case, I think NYU, it's pretty much a uniform disaster throughout the country when it started. Because of that, people hate the endoballoon and think the endoballoon is dangerous. Well, partly because there were 8 things that were trying to be learned all at the same time. TEE was brand new. So I think it's important to recognize that and then initiate these learning curve experiences as much as possible before you start with the robot or before you start with the thoracotomy approach.
Yeah, Sloane, I love your analogy of the 5 families, and for those who didn't get the allusion, it refers to the 5 families in The Godfather, that probably the greatest...
In New York City.
In New York City, that's exactly right. Yeah, I wish you'd had that slide up, so that's a great analogy. I would like to say one other thing about the culture of safety, which I have, very early on, I incorporated into the team, was that if it was a mitral case, say, or whatever the case was, let's say it was a mitral valve repair and it was posted as a minimally invasive mitral valve repair, I emphasized to them that the patient has come to us for a mitral valve repair. That's the most important thing. In other words, at the first sign of trouble, at the first sign of any, even if I think there's going to be a problem, we are going to convert and make a sternotomy, and that is not a failure, that's a success, because you have stuck with the core principle of safety. And when you do that, there's no buzz in the operating room that happens afterwards saying they failed, because we didn't fail. And it seems like a trivial thing, but it's not. It's changed the entire culture. And I think that's very important.
I don't think it's trivial at all. And I used to be a pilot, and there's something called a go-around. When you're coming in for a landing, if things aren't perfect, you should just put full throttle and go around and try again. I've done that in an aircraft. It's very embarrassing. If these guys were with me, they'd be like, what's wrong with this guy? He can't land the airplane. Are we in trouble here? It's embarrassing. But really, that's the master pilot that does that. They put their ego aside and they go around. There's been many high-profile airline accidents where they didn't do that and they crash coming in on the runway. I would liken a conversion to a go-around. And there's a reason why in the airline industry, most of the major airlines do not consider a go-around as a negative marker of performance on the part of their pilots. Same in surgery. When we started doing laparoscopic cholecystectomy when I was a junior resident, this was very much emphasized because more patients got hurt by lack of conversion during the development of that procedure than not doing it. So we emphasize the same exact thing, and I do not hesitate to turn into the most old-fashioned surgeon, zip that sternum and be done with it when necessary. I think it's critical.
Can I ask quick, Dan, to all 3 of you, actually? Mahesh brings up a very interesting point, and I think for the junior folks in the audience and people that are starting to get into this and have been very, very well trained to do open heart surgery the way we traditionally do it, which is not easy to master and is not easy to have good results with. Everybody goes through their training and then becomes a junior surgeon and is able to kind of slowly get through their process. And then transitioning into a minimally invasive surgeon is a step beyond that, and everybody needs to go at their own pace. But the question that I had, Sloane, you mentioned this a little bit. You had a patient that you talked about that had AI that required you to put the CS catheter in or use CS retrograde plege, but not enough to convert to a sternotomy and do a double valve.
Yes, correct.
And for all of us, I think there's a psychology involved. How hard is it for you to walk into the operating room in the morning and see an echo finding, something that will change the course of your day? We all try to philosophize the fact that, no, we shouldn't do that. What should the threshold be? And is it easily attainable at this level when you're really into doing everything minimally invasively, and that's kind of what you do, it's what I do. There's some psychology to actually changing course whether it's at the beginning of the day or if it's in the middle of the day, and how long, how did you train yourself? Like, I remember when we first started taking down mammaries with the robot, it would be 1 hour and then no more after that, convert.
I think there's been a lot of, it's a great question, Sam. There's been a lot of surgeons that get into trouble doing 8-hour mitrals minimally invasively, and these are the sort of absurd cases we hear about. There is a time to do it. Now, I'll use another flight analogy to answer your question. When you're flying and you start to lose lift and you're about to stall, a little stall alarm goes off. And you know that you're about to lose lift on that wing, and you better either turn the power up or you better nose down a little bit, or else you're going to fall out of the sky. I don't know who gave it to me, but I have one of those embedded in me for minimally invasive surgery. And that alarm goes off where I know things aren't going well, and it could be early. I had a case last month where I put that first port in, like I showed you, and blood started coming out. I put the camera in. There was tons of adhesions. The patient had had radiation, et cetera. I looked at my team and I said, hey, guys, no big deal, but we're not doing this minimally invasive. Take everything out. I scrubbed out, gave the team 15 minutes to set up for a sternotomy, did a sternotomy. We were done by 10 o'clock. No, no big deal. I do think you have to use good judgment. The other thing I do is I also consult my teammates. So if you're having trouble making a decision, get some discussion going in the operating room. There's no place for arrogance in minimally invasive surgery. Hey, what do you guys think? Do you think we should persist? What's your opinion? If we have AI, I had a lengthy discussion in that case with the anesthesiologist. Do you think we should replace this valve? Forget robotics. If this were a full sternotomy, would you think this is enough where I need to replace this valve? What do you think? And at some point, you can't be indecisive either. But it's good to collaborate with your team members for a variety of reasons. Number one, they may know something you don't. They may push you to leap over that threshold that Sam's talking about, where you're sort of resisting conversion because they don't have the ego you have. And then number three, when you do make a decision, if they've been on board, if they've helped you develop that decision, then they'll support that decision. They'll say, yeah, he did the right thing because that's what I recommended he do, or whatever, So it is a team sport, and I think the team approach to these decisions help. But don't go too far with that and be indecisive, because the team does need you to make these decisions.
Yeah.
Yeah, great session.